So thank you all for joining us. I know this is kind of a wild time, so this new hybrid model, but it is wonderful to see each of you that is here in person, and welcome to everyone who's joining us online. I'm excited today. We're going to talk about small cell lung cancer. We'll cover an array of topics, and I have some exceptional colleagues joining me up here. So start out, Dr. Tiziana Leal, I'll let you introduce yourself.
Good evening, everyone. I'm Tiziana Leal. I'm a medical oncologist, and I specialize in thoracic oncology. I'm an associate professor and director of the Medical Thoracic Oncology program at Winship Cancer Institute of Emory University. Very happy to be here today to have a discussion about small cell lung cancer and treatment advances.
And Dr. Nisha Mahindra, probably the closest drive, at least for us up here. Let you introduce yourself.
Hi, I'm Nisha Mohindra. I too am a thoracic medical oncologist here at Northwestern. I'm an associate professor and also manage our both our inpatient and outpatient oncology thoracic units. Welcome back to Chicago, guys.
Thank you. And I'm Dr. Jacob Sands. I am a thoracic medical oncologist at Dana-Farber, where I lead our small cell lung cancer program. So it is exciting to get to join all of you and talk about small cell lung cancer. So I'll just maybe briefly, rather than going through this slide, we're essentially going to start with talking about in the first line, and then we'll go into second line and beyond, and then some of the novel treatments and ongoing studies. So to start out with, the diagnosis of small cell lung cancer. So this is a slide on the right for just a general depiction of small cell lung cancer. Generally speaking, the majority of these do express TTF1 on IHC stains. That is not absolutely necessary, but it is commonly seen. And most do express neuroendocrine differentiation. Of course, that's the classic for diagnosing small cell with synaptophysine chromogranin CD56. Small cell lung cancer has a high mitotic rate. This is a very transcriptionally active cancer that leads to rapid disease progression. As far as historical context, I often will show this slide here with just this steep slope. I had an attending in fellowship who would, during journal clubs, see a slide like this from the back of the room. And his definition of a terrible prognosis was the fact that that slope is not skiable. And unfortunately, for a lot of small cell lung cancer, these slopes are not really skiable because there's such rapid drop-off. Now, cisplatin etoposide, or now carboplatin etoposide, these are regimens that really come from the 70s. This has been a standard of care for a very long time, although really it wasn't established until a couple decades later. Of course, there was a time of CAV versus platinum etoposide consideration, although platinum etoposide did become very across the board the standard of care until more recently. Response rates are pretty high with platinum etoposide. Often patients come in, even when admitted to the hospital, with rapidly progressive symptoms. I certainly see plenty of people that end up with a new oxygen requirement that once starting platinum etoposide inpatient have a rapid enough response that they actually end up leaving the hospital without needing oxygen. So we certainly see a rapid improvement in symptoms when starting treatment. That being said, we've certainly built upon that, and we'll get to that. Now, there's the advances that we've seen in non-small cell lung cancer and other fields that have really been so plentiful over the last decade. We've really only recently started making some progress in small cell lung cancer during that time frame. And I think there are a lot of barriers really to advances in small cell lung cancer. Of course, these are patients often with a very extensive smoking history and therefore multiple comorbidities. The disease itself is rapidly progressive, and that can make it more difficult to enroll to clinical trials when patients really need to start treatment very quickly. This is certainly a discussion point we have in first-line clinical trials setting, where if patients need to go onto the trial before they start any treatment whatsoever, that can be a limiting factor. And so in some cases, I really encourage to allow for a single cycle of treatment before then enrolling, because then we actually can get more people on. The other thing is that if a trial requires biopsy, a fresh tumor biopsy prior to treatment, which certainly we see in various cancers where there are certain stains or other testing that you want done when enrolling to a study in small cell lung cancer. That's not really feasible because patients often need to go on very quickly. And so we've had limited tissue, we've had limited opportunity for enrolling to studies, and this has all really added up to a more challenging setting. I'll just briefly touch on this because TMB is not currently really part of the paradigm for small cell lung cancer, but you do see that it is more to the right there as far as the diagnoses with a higher tumor mutational burden. Melanoma really being on the far right, and melanoma really being the starting point for a lot of our immunotherapy advances that have come down the line. And then squamous cell and adenocarcinoma, of course, coming next. Small cell lung cancer with a pretty significant tumor mutational burden, although that becomes more relevant, particularly in the setting of immunotherapies, although TMB is not really a defining biomarker for that within small cell. As far as the common genomic alterations for small cell, P53 and RB1 have similar functions in that the two of them really serve as brakes in some way for stopping the replication process to allow for repair of the DNA. And so it helps prevent passing on these mutations that occur in the process. And so when those are not functioning, it's essentially like the brakes not functioning. MYC, in some ways, is more like the gas pedal. MYC proteins activate the expression of genes enabling proliferation, therefore moving the process forward faster. And this is, in fact, amplified in about 20% of small cell lung cancer. So in that case, it's really like the brakes being broken and the gas pedal being pushed down. Now, although I've presented the fact that we've had multiple reasons or challenges for advances in the field, we have more recently started seeing real advances. And so we're coming into what I think is an exciting time academically for small cell. Of course, nobody wants to be in a situation where they need these advances. But academically, this is an exciting time in that we are seeing advances, and we're going to touch on those. So we'll get into first-line therapy in a moment, and then that'll follow with second-line treatment. And there are an array of really drugs to discuss in the second line and beyond. Now we're going to start out with a case, and so I'll go through this. 65-year-old patient with a past medical history of hypertension, hyperlipidemia, so common kinds of comorbidities, 60-pack-year smoking history, presented with a persistent cough and generalized fatigue, had an ECOG performance status of 1. Initially, a chest x-ray showed a mass, and of course, a CT scan follow-up then showed both a 4-centimeter left upper lobe mass along with left hilar lymphadenopathy, bronchoscopy, diagnosis of small cell lung cancer. That'd be a real curveball if the diagnosis wasn't. So diagnosis, small cell lung cancer. MRI was negative. PET CT done for staging revealed multiple FDG avid hepatic metastases. So metastatic small cell lung cancer, and now presents for further management. So first-line therapy, I will, I'll pass it off to my colleague, Tiziana.
Okay, and we'll talk about, I think, some of the nuances of that prior question as we review the data for both IMpower 133 as well as the Caspian study. So let's start with the IMpower 133. This was a phase 3 study investigating atezolizumab, a PD-L1 inhibitor, in combination with our standard chemotherapy backbone in patients with untreated extensive stage small cell lung cancer. So in this study, patients had to have measurable disease, good performance status, and in this study, they did not allow untreated asymptomatic brain mets. So patients had to have treated asymptomatic brain mets. 403 patients were enrolled and randomized 1-to-1 to atezolizumab, the PD-L1 inhibitor, in combination with our standard chemotherapy backbone, carboplatin and etoposide, followed by atezolizumab maintenance. In the control arm, patients received placebo and had the combination of carboplatin and etoposide followed by placebo maintenance. So in this study, patients were not allowed to receive cisplatin. In this study, PCI was per local standard of care, and thoracic radiation was not permitted on either one of the arms. The co-primary endpoints included overall survival and investigator-assessed progression-free survival, and key secondary endpoints were overall response rate, duration of response, and safety. So here are the results of the Empower 133. Now, with further follow-up that we've published in JCO, the median follow-up is 22.9 months, demonstrating the sustained benefit with the addition of atezolizumab to chemotherapy for patients with treatment-naive extensive-stage small cell lung cancer. The median overall survival is 12.3 months versus 10.3 months, with a hazard ratio of 0.76. And we see here with further follow-up the OS rate at 18 months, 34% versus 21%, which when you think about the historical controls, actually this is favorable for both arms. But certainly here you see a modest benefit, a subset of patients really deriving benefit from this strategy. In terms of safety results, we've also seen with further follow-up no significant safety signals. The combination of chemo plus immunotherapy with atezolizumab has been well tolerated. The majority of the side effects that we see are what we see with the standard chemotherapy backbone and myelosuppression. And we do see some immune-related adverse events in all grades, 39.9%, and atezolizumab, we saw 24.5% in placebo. Keep in mind, this was actually a double-blind study, so I think obviously that's why you see immune-related AEs in the placebo arm, and low rates of treatment discontinuation, and certainly low rates of treatment-related deaths. And in terms of the median number of doses received, for both arms in terms of the chemotherapy, the dose intensity was the same for both treatment groups, with a median number of doses of atezolizumab of 7. Now let's move on to the Caspian study. This is another study that led to approval of durvalumab. Empower led to the approval of atezolizumab. This is another PD-L1 inhibitor. Similar study design with some differences here. Patients with treatment-naive, extensive-stage small cell lung cancer with good performance status were enrolled in this study. It did allow asymptomatic or treated and stable brain mets. 805 patients were randomized 1:1:1 to the durvalumab plus chemotherapy arm. In the durva plus chemo arm here, it did allow for cisplatin or carboplatin, although the majority of patients did receive carboplatin here, followed by durvalumab maintenance in this arm. The control arm was EP, which is standard chemotherapy backbone, and they were, in this arm, allowed to receive up to 6 cycles. And PCI was optional in the standard of care arm, however, not permitted in the experimental arms. There's a third arm, which is the top arm, which investigated tremelimumab, a CTLA-4 inhibitor, in combination with durva plus EP for 4 cycles. And in the experimental arms, patients went on to receive maintenance durvalumab until progression. None of the arms were allowed to receive thoracic radiation. The primary endpoint here is overall survival. Secondary endpoints included progression-free survival, overall response rate, safety and tolerability, and patient-reported outcomes. And here we have the results of the phase 3 Caspian study. We now have a 3-year overall survival update, and some sort of the highlights of these results that we know are that the combination of durva plus chemotherapy led to improved overall survival in patients with untreated extensive stage small cell lung cancer. You can see there the median OS for durva plus EP is 12.9 months versus 10.5 months, and the hazard ratio here is 0.75. Now, the addition of tremelimumab, the CTLA-4 inhibitor, did not lead to significant improvement in overall survival and was associated with more toxicity. You see the 3 curves there in terms of overall survival, showing a numerical sort of comparable outcome with the durva plus tremi plus CP, but that was not statistically significant. And certainly the higher rates of toxicity, including grade 5 toxicities, really have led this combination to not be something that we use in clinical practice and certainly not approved. So CTLA-4 inhibitors in this setting at this time remain investigational. And here we have the 3-year overall survival update, and this is the longest follow-up we have from these frontline studies. We have a median follow-up here of 39.4 months, and you see here at the 36-month probability of OS, superior in the durva plus EP arm of 17.6% versus 5.8%. Hazard ratio here remains quite significant with 0.71 as is shown here. I think one interesting thing about all of these studies that you'll note is that we really don't have any predictive biomarkers for selecting patients who are most likely to benefit from this strategy of immunotherapy plus chemo. We've looked at, TMB, we've looked at blood TMB, we've looked at PD-L1. None of these have been predictive of benefit, so these are really approved for all-comer population. And similarly, in terms of the safety results in the Caspian study, the addition of durvalumab to chemotherapy was well tolerated with overall, in terms of the immune-related AEs, the experience has been what we would expect for the combination with immune-related AEs of all grades, 36% in the durva plus tremi plus EP, 20% in the durva plus EP, and then in the EP, 2.6%. In terms of AEs leading to death, and this is where we see more toxicity with the durva plus tremi plus CP, 10.2% versus 4.9% in durva plus CP. So again, I think the toxicities here of tremi really outweigh any potential benefit and no overall survival benefit at this time. So not something that we're using, but certainly durva plus CP, well-tolerated regimen. So what we see here is our new standard of care for frontline treatment for patients with extensive stage small cell lung cancer. We have 2 approvals, one based on Empower 133 with atezolizumab in combination with chemotherapy, improving overall survival with manageable side effects. And then subsequently, we also had approval of durvalumab based on the Caspian data in combination with chemotherapy, improving overall survival without toxicity, and certainly tremi plus durva plus chemo, not prolonging survival in a statistically significant manner, so not approved and not standard of care. We have 2 other trials that have also sort of supported the use of immunotherapy in the front line. One of them was combination of pembrolizumab with chemotherapy in a phase 3 setting. The Keynote 604 data, which showed similar survival curves, again, did not meet statistical significance, so not FDA approved, but certainly I think really establishing the use of IO in the front line and perhaps a backbone to use for future clinical trials as we build upon these results to really get better outcomes for our patients, as this is a modest improvement and further improvements are needed. And then we've also seen the data for Nivo plus chemo based on our ECOG-ACRIN study, EA5161, adding nivolumab to chemotherapy in a randomized phase 2 setting, also showing similar OS benefits as well as PFS benefits. So certainly first-line chemo IO is here to stay. The challenges remain: who are the patients most likely to benefit from this strategy? Can we find predictive biomarkers for patients and really kind of define and outline the best treatment options for patients in the frontline setting? So let's go back to our case.
So just to, rather than go through all of this, is essentially a patient who presented with ECOG-1, performance status, not much in the way of comorbidities, metastatic disease, 4 centimeters left upper lobe with hilar adenopathy, and mets to the liver. So before we get into some of the immunotherapy stuff, let's start basics. Carboplatin versus cisplatin. Do you have a strong preference about those? And then also we'll get into atezo and durva as well, and whether there's a situation, whether you generally prefer one over the other, or if there are situations in which you might use the opposite of your choice. Either of you, please feel free to answer one or both of those.
Nisha, do you want to start?
Sure. So for most of my patients, it depends on their performance status, especially with the carbo-cis decision. I often will use carbo up front if I'm worried about their performance status. Thinking about the IO partner, a lot of times, for me, I find that there is probably equipoise between the data. So I base it off of if there are some potential clinical trials that we have that may play into what they could be eligible for next. And I think we'll talk about that at the end, our last section, some of the stuff that's coming up. I don't know, what do you guys prefer?
Yeah, in terms of the carboplatin, cisplatin, I think, beyond the data that we saw here, I think a few points. We've seen data and we've seen data from the VA cohort of patients comparing cisplatin to carboplatin. We've seen data in older patients comparing cisplatin to carboplatin. And sort of the bottom line is that it doesn't really improve overall survival if you use cisplatin over carboplatin, but we do see more toxicities with the cisplatin-based combination. So unless I have a really good reason to use cisplatin, which I find myself rarely actually seeing that in clinical practice, I really do prefer to use carboplatin in our patient population that is older, has more comorbidities. If there's no improvement in overall survival, I don't think there's a great gain in that. But I think this question might be trying to go back to sort of the original data about which regimen has been investigated with cisplatin, that if you were to use cisplatin, would you then follow the data and sort of see what combination you would use? Now, that being said, I don't think that from an efficacy or a safety issue I would have concerns, but I think if you follow the data, only one of the regimens really investigated the use of cisplatin, which was the Caspian data. However, even in that data set, the majority of patients did receive carboplatin. I think in terms of the two agents, I agree that the two agents and the two studies have a lot of similarities in terms of the gain and the magnitude of benefit. Certainly, I think it's reassuring to see greater follow-up in the durvalumab data. It's really nice to have that 3-year overall survival data with the Caspian. We also have some interesting data that was recently published with the Caspian data in JTO just last month, I believe, showing sort of the brain met cohort, looking at the benefit of adding durvalumab to chemotherapy in patients with or without brain mets, showing similar magnitude of benefit, but also in an exploratory cohort, also showing sort of a delay or a prolongation to actually patients needing radiation or developing brain mets. So exploratory, but certainly interesting. I think if we had more data to kind of differentiate the two, it would be helpful. But I think overall, putting it all together, I would say that both, I think, are acceptable in terms of using them in clinical practice. And I've used both, and I don't think there's any different in safety or tolerability either in clinical practice.
So to summarize, what I hear you saying is that you prefer carboplatin, and if you were using cisplatin, although technically that would require durvalumab based upon the data, you'd feel pretty comfortable swapping out atezo and durva, and you think of these as fairly comparable.
Yeah. I probably would follow the data and use cis-durva combination, but if, let's say, it wasn't formulary in my institution and I really wanted to use cisplatin for a reason, I would.
Yeah, I feel very similar. I think of carboplatin and cisplatin as being pretty comparable at this point. I think historically these were thought, there was a push for cisplatin over carboplatin, although in the metastatic setting I think that's gotten less and less. There's an increasing preference for carboplatin, although some institutions I do still see have a preference for cisplatin. And as far as atezo and durva, I think of them as very, very comparable. Now, actually, to that point, actually, we're going to get into some discussion of Pembro and Nivo and other checkpoint inhibitor, PD-1, PD-L1 inhibitors. But just since we're in the first-line setting, you mentioned the Keynote study. Of course, there's also been Nivo studies in that space. You mentioned the curves look fairly similar. Of course, the FDA approval is atezo and durva. Do you think of these then as fairly similar drugs, or do you think of these as there being big differences?
I mean, certainly Pembro and Nivo are PD-1 inhibitors, but I do think that when you put the curves and obviously doing the cross-trial comparison with all of its caveats, the curves look very similar in terms of OS as well as PFS, and the numbers are very similar. There's differences in study design, there's difference in patient population, so they're not comparable, perfectly. But I would say that although Pembro and Nivo don't have FDA approval in frontline, and I wouldn't use it with a standard chemotherapy backbone, as we're developing new clinical trials, investigating new agents with a backbone of combination of chemo-IO, I'd feel very comfortable using Pembro or Nivo as a standard backbone for further investigation.
Yeah. Agree. So the question actually comes up. So maybe more specifically, is there anything that would make you choose atezo or durva? Nisha, do you want to start with that? Is there anything that would make you choose one over the other?
You know, I agree with Dr. Leal. There is, I guess, longer follow-up data from Caspian, but, you know, I have not found that in practice I'm choosing based off of that. Like I said, there are some interesting trials where certain backbones are part of the trial, and so that's how we're using our decision making. That's how we're doing our decisions at our institution. And I think the CNS data is intriguing, but you know, I have not had a strong preference to either agent.
And I would agree. I mean, I find myself kind of using them interchangeably. And I do think one thing about Empower, as you saw in the FDA approvals, it was approved first. So I think there's something to say about having that first approval, patterns of care where people started using, you know, carbo-topotecan for almost a year before Durva finally got approved. So I think a lot of people just were very comfortable with, hey, this is the regimen that I'm using. I'm, you know, comfortable with the dosing strategy, and I know kind of what to do with this regimen. And so I think, you know, the Empower 133 regimen certainly had the advantage of that initial and first approval and sort of establishing that pattern of care for a lot of clinicians around the country. So I do think that it does have that advantage, which is an important one.
So this is an interesting question, and this is more for the pathologists maybe, but the question is, could you elaborate further on the diagnosis of small cell lung cancer? Pathologists often report suggestive of or consistent with high-grade neuroendocrine carcinoma without necessarily specifying. How do I know if this is small cell, large cell neuroendocrine, high-grade carcinoma, or something else? And, you know, I mean, this is obviously something that really ends up being a discussion with the pathologist. On some level, I guess maybe the question to pull from this is a large cell neuroendocrine. This is, you know, a related topic maybe, but we can touch on this. So large cell neuroendocrine, there's kind of a spectrum of what you can do in that. I know this topic we're discussing is really more classic small cell, but, you know, this is something that comes up. In that setting, how do each of you consider treating that, and what's your thought process through that?
And, you know, I go back and I call the pathologist and we'll have a discussion. You know, it depends on the size of the sample. One of the things that you talked about is a lot of times when we get a diagnosis of small cell, we have a very sick patient, the sample is very limited, and the pathologist has limited tissue to work with. That tissue may have a lot of crush artifact. This is a high-grade tumor. There's a lot of necrotic cells. You know, typically I think for them to call it small cell, they kind of want to have that perfect scenario with the TTF1 positive, CD56, synaptophysin, chromogranin. And so if some of those things are missing and it looks like a high-grade tumor and you have limited tissue, you know, they will tend to call it high-grade neuroendocrine carcinoma. And if you give them enough clinical context, you know, you can kind of say, can we put it into clinical context and call it small cell? And then, you know, we have that discussion in our multi-D, you know, thoracic groups, and then we can finally get a diagnosis of small cell. But I would say if I have a diagnosis of high-grade neuroendocrine carcinoma in the correct, or, you know, the clinical scenario that fits with small cell lung cancer, I'm going to treat it as small cell lung cancer. Now, the large cell diagnosis is a little bit different, where, you know, you have this diagnosis of clearly the cells look different and they are calling them large cell neuroendocrine carcinoma. And certainly it falls into that spectrum of small cell, and those patients a lot of the times are treated as if they have small cell, although they don't really behave like small cell. They don't have that rapid initial clinical response. You don't see the response rate of 60%. They do behave differently. And I think there's still a lot of question in terms of the large cell neuroendocrine carcinoma population. Are these genomically different? And how do we treat these patients? But I think, you know, ultimately they end up getting treated with chemo IO for the majority of the patients, kind of like small cell, although they're not truly.
Yeah, and I that's kind of where I was leaning and asking the way that I asked that too, is that think if you have something that you can't differentiate with the pathologist as large cell neuroendocrine or small cell, this becomes a morphologic question in some ways. But if it is something where the Ki67 is high, where it's a there are multiple mitoses in the field, then I'm more inclined to treat that like small cell anyway. And sometimes deciphering that isn't necessarily extremely important in the initial therapy. But of course, at the same time, on the spectrum, then if you have a large cell neuroendocrine that does not have a lot of mitoses, that doesn't appear, that doesn't have other factors of it that are more consistent with an aggressive small cell diagnosis, then of course you can consider non-small cell therapies. All right, so now this is the discussion we've kind of already started, really. Another interesting question that came up is around, well, it says radiation for metastasis. Now, that's a broad statement. I'm not sure. Whoever asked that, please feel free to clarify if we don't cover this. We're going to get into some second-line discussion. And where I'm going to take this question then is, let's say you give chemo plus PD-L1 inhibitor, and now you have general disease control, but you have 1 or 2 sites of progression with ongoing control otherwise niche. What would you consider radiation in that case? Is there a scenario where you would do radiation for one of these patients while continuing the checkpoint inhibitor, or is progression?
You know, I think it's an interesting question because there are patients, it's a handful, where they've had a prolonged time on IO in the maintenance setting, and then will have a lesion come up. And I think it depends. In that case, I have used radiation and continued IO with a very short interval of follow-up, again, making sure I'm not missing, fulminant progression. But I think if they've had some time on IO away from the platinum, I have used that strategy. Have you guys?
Yeah, I'll say, especially if it's in brain, in someone who has not gotten whole brain radiation and now they have 1 or 2 sites in brain. I actually have a patient that I treated on atezo, chemo atezo, and was on atezo for 3 years with multiple instances of some brain mets that were treated with SRS. But eventually, complete control, unfortunately then developed an early stage pancreatic cancer. To which I told the pancreatic team, hey, treat her like she doesn't have small cell because it's been 3 years of control. She actually got neoadjuvant treatment for that, got a Whipple, and has been doing well now for a while. So hopefully that will persist. But, we see some of these people with just magical responses to checkpoint inhibitors with ongoing years of control. And so I'm sure you have some outliers like that, hopefully without the pancreatic cancer scenario, but years of control. That's particularly in brain. But I would do that even if it was like a chest wall or a adrenal progression with otherwise multiple sites that are clearly under control. I would consider that as well. All right. Let's see. Did I have? Well, maybe just a brief point. After completing the chemo, so 4-6 cycles, I see 6 commonly done, which is why I raised the question. The trials were obviously 4. And then the dosing of atezo or durva in the maintenance setting, what is your frequency of that?
So for the number of cycles, I go with 4.
Yeah.
So I don't think there's really additional benefit for 6, certainly increased toxicity, and no real data to support in terms of overall survival. I think we had this really old dogma of, okay, do 2 cycles beyond your best response. And so I think people at the time when we didn't have other options just felt like more chemo was better. The reality of it is I don't think that's really the case in small cell. So I tend to do 4 cycles as my routine. In terms of the maintenance strategy, I do atezo every 3 weeks. I know we can use every 4, but I generally just continue on every 3. If there is a reason that a patient, it's significant for them to have that, interval of 4, I would do atezo every 4. And with durva, I go with every 4 durva when I use durvalumab.
Yeah, I have a similar approach. I usually will stop at 4 cycles, and then Same with Durva. I try to do the every 4-week dose, and Atezo, I leave it up to patient preference. And I think these came up a lot, certainly with COVID, and trying to think through frequency of visits and a lot of shared decision making in terms of how to look at how often.
Yeah. I think especially in the initial waves of COVID, I mean, obviously COVID is still around, but it's not like in that initial wave that we were really trying to reduce the visits. Another question is, so essentially around the goal. What is the treatment goal for small cell lung cancer? Are you trying to improve survival, reduce side effects, improve quality of life? There's a follow-up to this in asking about limited stage and extensive stage. Maybe we'll touch on limited stage in a moment. So we can introduce that in the first-line setting discussion here. But what's your goal in treatment? When you sit down with a patient and you're going over your initial counseling, what are the goals that come up in that discussion?
I mean, certainly for extensive stage, the goals would be ideally that you're reducing symptom burden and prolonging survival. I think small cell is such a symptomatic disease and can progress quite fast. So I am hoping for both.
Yeah, and I do have that initial discussion with the patient and their family and kind of try to meet them where they're at in terms of how much information are they seeking, what kind of sort of feedback they're giving me in terms of how much they really want to know at that initial visit. But it's a scary discussion because, having stage 4 lung cancer, they know it's really serious, but having, extensive stage small cell lung cancer and saying this regimen provides a median survival of 12.9 months, and long-term survivors in Empower 133 are defined as 18 months, that's very scary to hear. And I just had a conversation yesterday with a family member who's a physician, and she said, so what are the chances of my uncle being alive at 5 years of small cell lung cancer? And I said, well, the longest follow-up we have is 3-year overall survival data, and that's 17%. And she said, wait, do you mean 70? I said, no, 17. And that was shocking to her as a physician. And so I think it's really shocking to people who are going through this and somewhat discouraging. But I think certainly prolonging overall survival, focusing on the fact that you get rapid clinical benefit, that you can improve quality of life for the time that that person is living, and certainly that there is a gain in survival, and that gain, we wish it was longer. And there are some people who are outliers that we've seen. And I think there's room for optimism within sort of the treatment and the goals of care, but it's very important to outline that the goals are palliative and that we really have to work together every step of the way to make decisions together about what is in line with that person's goal in their life and their care, and the family getting involved in it too.
Yeah, I think your initial statement, it really hits for me the most, is that reading how much they want to know. And that's, I think, a nuance to oncology that I didn't really fully appreciate until being in oncology, is that what patients are able to hear at any given point it varies from person to person. And you have to be really careful not to just shut them off, where their minds just start spinning and they no longer hear what you're saying anymore. And that is a fine line, and it's different for each patient. And I'm sure those in the audience understand that. We all experience that in our own ways. But I think that's, I'll resist the urge to dive more into that topic, because I actually think that that's one of the most important in oncology, is how we interact with patients and educate them. But I will resist the urge so that we can cover small cell. I think for each of us, that's our own journey within the field itself, is gaining and understanding ourselves of how best to interact with patients. And the one other thing I'll say is that I think in small cell lung cancer especially, it's something that all of medicine tends to know of as a terrible diagnosis. And so patients often come in having been told essentially that they're going to die soon, in however that's stated. And so I often find that with patients, I'm having to really take a little more time to help get their feet on the ground a bit, which is frankly impossible, but enough to carry on in some way. And I do talk about the percent, that 17%. That is a horribly low number from what we want, yet it is also better than them just hearing the medians and saying, hey, there are patients that have years of control. That is unfortunately a fraction of individuals, but that's an important thing to be aware of. Maybe just for the sake of time, I'll just mention, limited stage, it asks for that. I think limited stage, the goal is cure. So we're willing to push people through more. Extensive stage, really the goal is extended quality of life. I find a lot of patients come in and really specify, hey, I don't want to live longer, I just want to have a better quality of life. And in some cases, I find that patients, and frankly, others in medicine, have an impression that chemotherapy or cancer treatment destroys people's quality of life, but makes them live longer, which sounds like the most awful thing, frankly, that our treatments are really to prolong quality of life, and therefore the side effect profiles are extremely important. And therefore, when we're talking about maintenance therapy with Atezo and Durva, which both have very favorable side effect profiles, that really is a win. Okay, so the case continues. Now, they've gone through first-line therapy, chemo plus Atezo, on Atezo maintenance. 5 months later, scans show multiple new bone mets. Performance status is preserved, so still ECOG 1. So now we're talking about second-line setting after a 5-month, we'll call it a 5-month chemotherapy-free interval on maintenance atezolizumab. So I'll kick us off in this. So platinum doublet re-challenge versus Topotecan. This was a study. Now, this one was, in fairness, in patients with a chemotherapy-free interval of at least 3 months. And in Europe, that's more common, whereas in the U.S., we tend to use 6-month chemotherapy-free interval as a time point where we would then give platinum doublet re-challenge. So in this platinum doublet versus Topotecan, you can see the progression-free survival looked a little better with platinum doublet, although overall survival was really no different between the two. Okay. Well, the comment I was going to make, I'll come back to later. So Lerbinectedin is a newer agent. This was approved in the second line after a basket trial with 105 patients. The mechanism of action of Lerbinectedin is, it has a few different, and I can't quite see the details, I don't know if you can, but essentially it ends up blocking transcription. It also has an impact in the tumor microenvironment with tumor-associated macrophages. And now tumor-associated macrophages, it seemed like it'd be a good thing having macrophages within the tumor microenvironment, but these can actually lead to increased inflammatory markers, increased VEGF, and so essentially these are factors that can enhance tumor growth within the microenvironment, and so therefore clearing of these tumor-associated macrophages, at least hypothetically, has an advantage within that setting as well. Now, this was, as I mentioned, approved based upon this basket trial, so this was 105 patients in a single-arm trial in the second-line setting. It distinguished sensitive versus resistant disease at a 90-day chemotherapy-free interval cutoff point. And on the efficacy here, hopefully you can see this better on the screens and on the pads in front of you, but the progression-free survival, you can see that the median progression-free survival was 3.5 months in all patients. Now, not surprisingly, the 90-day cutoff is really important in that those with a good response to initial chemotherapy or a longer response to initial platinum etoposide are more likely to benefit, therefore, from later chemo agents. And so, not surprisingly, we see better outcomes within those with a chemotherapy-free interval of greater than 90 days. Now, the medians are short, and the medians, I think, further stress the importance of ongoing clinical trials. But that being said, when we don't focus only on the medians, we, of course, do see patients with more durability to that. And you can see that the 6-month progression-free survival in those with more than 90-day chemotherapy-free interval was actually around 44%. So you still have a good number of patients that have durability in responses. And then you see overall survival there on the bottom. And the 12-month overall survival in those with a chemotherapy-free interval of at least 90 days was 48%. Now, it of course looks worse in those with progression at less than 90 days. And in fact, For those with a chemotherapy-free interval of less than 45 days, so a truly resistant or refractory disease, Lerbinectedin is really the only FDA-approved drug. Topotecan was approved at 45 days and 60 days based upon PO and IV dosing. Now, the numbers are low, 2.6-month median progression-free survival, and only 19% of patients with ongoing disease control at 6 months. But in this population with a horribly poor prognosis, I guess I go back to my statement before about the importance at the time of diagnosis and saying that 17% number at years out is a low number, and that's a really, this obviously is something that we need to improve upon. But for an individual with this horrible prognosis who has more than 6 months of ongoing disease control, that's extremely meaningful for those individuals. And so this drug is certainly providing some benefit to a fraction of patients, obviously still a lot of work to do, but a portion of patients that are particularly benefiting. Now, you see on the right here the swimmer's plot showing those with a chemotherapy-free interval of greater than 90 days being the darker blue. And so not surprisingly, as we discussed before, the greater durability you see generally within those patients. There is one that's up there. I think that's 9.1 month without progression in one of the more resistant patients. And the curves there on the left side, the scale is not the same on those, so the shape of the curves can be a little bit deceiving in that. As far as the safety, thankfully this was pretty well tolerated. As far as side effect profile for Lerbinectedin, really the big thing is cytopenias. Now you'll see that neutropenia was particularly prevalent, 21% grade 3 and 25% grade 4. I'll point out that in the trial, patients were not allowed to get prophylactic GCSF. And so had they been getting that, presumably the numbers would be lower. That being said, only 5% of patients had febrile neutropenia. But meaningfully, I'd say more so even than the neutropenia is the fatigue. And only 7% of patients had grade 3 fatigue. And at the time of initially looking at the data, I thought, well, maybe that might just be more so people with small cell lung cancer, and it can be hard to tease apart if they're not really having much of a response, if in fact the small cell is potentially causing that. But I've used Lerbinectedin quite a bit now, and I've certainly seen some of this. Thankfully, it's been minimal. I have a couple patients in which fatigue was really enough that we needed to stop the drug. One in particular where it was so severe that really after a couple doses had to stop the drug and couldn't give him another dose. But that individual had rapidly progressive disease at the time of initiating Lerbinectedin, had a really nice radiographic response, and even after stopping the drug had another 4 months of ongoing disease control before his cancer did then unfortunately become rapidly progressive once again. So he really did have a very aggressive small cell and had very clear control despite being off the drug, but fatigue was something that required stopping the drug. Now, before I get into this is a poster. This is from the abstract of a poster being presented here, but maybe it's really first important to point out that there was the Atlantis Trial, which was a combination of Lerbinectedin plus doxorubicin versus CAV or Topotecan. And that trial was negative. And so the combination of doxorubicin and Lerbinectedin is not being further pursued. The curves look very similar. I guess the hopeful thing I could say is that similar to the prior Topotecan study where we saw Topotecan versus CAV, those curves looked similar, but that was at a time where there really weren't treatments for small cell lung cancer, and so that did end up leading to an approval for Topotecan. That being said, we have multiple treatments now, and so something that doesn't look, a negative trial is a negative trial. And so the combination is not being pursued. One aspect of that as well to point out, though, is that Lerbinectedin was dosed at 2 milligrams per meter squared in the combination with doxorubicin, whereas the single-arm study, it's 3.2 milligrams per meter squared. The only reason I mention that is that when treating patients on a single-arm trial, it might be particularly meaningful with this drug to really try to maintain that dosing versus dose reductions. Now, this is a poster to be presented here at ASCO, and this is taking the patients in that Atlantis trial who had completed 10 cycles of combination Lerbinectedin plus doxorubicin that then went on to Lerbinectedin alone. So they really got full doxorubicin dosing. So this is really selecting out the individuals who are doing the best on this on that arm. Interestingly, from within that, the 19 patients that had stable disease at the time of completing those 10 cycles of combination, 2 of them went on to have a partial response on the Lerbinectedin alone at the increased dose, and 1 went on to have a CR. Now, these are small numbers, and again, this is a negative trial, so the combination itself is not something that I would do or is recommended, but I think that speaks to at least questioning that dosing and a hypothesis that that dose really matters, that 2 versus the 3.2. Now, Topotecan, there's both PO and IV. On the left side, PO, this is versus best supportive care. This was in patients with a borderline functional status, hence the best supportive care control arm in a publication in 2006. And on the right there is IV, and that's what I was referencing a moment ago, CAV versus Topotecan, but the Topotecan was better tolerated and therefore led to approval. On the right side there, the IV was at those with at least a chemotherapy-free interval of 60 days, and that is what the FDA approval says. On the left, the PO is 45-day chemotherapy-free interval. As far as the safety profile on this, we do see certainly cytopenias, as well as fatigue with Topotecan as well. Not surprisingly, oral does have a bit more as far as GI toxicities. And so these are the 2 FDA-approved regimens, but now we'll dive into other second-line therapies and beyond.
So there has been not a dearth of trying different agents in recurrent small cell, and we're going to highlight a couple of the agents that have been utilized. And again, we're going to see even at this year's ASCO some of these agents coming back in different combinations. So one of the agents is Irinoteken. Just for review, it's a topoisomerase 1 inhibitor, and topoisomerase is generally utilized to relieve the torsional tension that happens during DNA replication by creating single-stranded breaks. So when you inhibit this, it prevents religation of those cleaved sites and ultimately cell death. So this was initially studied back in the early 90s. It was in, one of the first trials was a small trial, 15 patients, recurrent disease, so either after limited stage or extensive stage. And what we saw was that there were about 47% responses. You can see that some of them happened after limited stage, some after extensive stage. Median duration of response was about 2 months, and OS was a little around 6 months. Another agent that has been utilized is Paclitaxel. Just as by way of background, it comes from the Pacific U bark. What this agent does is it binds to microtubules and it promotes microtubule assembly and kind of prevents the disassembly. And the reason this is important is that you need that dynamic microtubule movement for mitosis. So when you prevent disassembly, it prevents the later stages of mitosis. So this agent has been evaluated in kind of 2 dosing regimens, 175 milligrams per meter square every 3 weeks, as well as 80 milligrams per meter square weekly for 6 weeks on an 8-week cycle. Again, these are small numbers. In the first dosing regimen, 21 evaluable patients, PR or response in 29% of patients. In the second dosing regimen, similarly, we saw a response around 24%. In that second trial, they kind of tried to break it up between, sensitive disease and refractory disease, and we saw a slightly higher numerical response rate in the sensitive disease than in the refractory disease, which is what we generally see in practice as well. temozolomide. Again, we'll see in ASCO this year a presentation of this with in combination with a PARP inhibitor. So this is a prodrug that's rapidly converted into a metabolite that acts as an alkylating agent and leads to DNA damage and then apoptosis. It's important to note that temozolomide does have significant penetration of the blood-brain barrier and can be an important consideration when you're thinking about who to use certain drugs with. Again, this too was looked at in 2 dosing strategies, so we'll go through the first, which is 75 milligrams per meter square per day, oral for days 1 through 21 of a 28-day cycle, pre-medicated with ondansetron. In this trial, they kind of defined sensitive disease as a 2-month interval from the last platinum and refractory disease as less than 2 months. But similarly, we saw that the response rate in the overall population was about 20%, and then when they broke it up by sensitive disease, it was closer to 23%, and refractory disease, 13%. An interesting thing to note in this trial was that they did look at CNS response in some of the patients who had baseline measurable disease, and they saw 38% CNS response. Small numbers, but again, looking at some of these older agents. Time to progression in either cohort was less than 2 months, so certainly things to improve upon. With temozolomide, there is a good amount of hematologic toxicity, so another dosing regimen was looked at. Now this was 200 milligrams per meter square per day for 5 days of a 28-day cycle. And again, it had similar response, numerically, it was 12% response. There were fewer dose delays due to cytopenias. It was generally better tolerated. Importantly, when you're comparing these numbers, there were maybe more sensitive patients in the 21-day cycle trial, but again, small numbers and certainly things to improve upon. So there are a number of regimens listed on NCCN, and you can see, as Dr. Sands referred to earlier, that a lot of times the way that we classify these are less than 6 months and greater than 6 months. And there's, a laundry list to choose from, but I know that there's a lot of nuances in who do we choose and what do we do next. 2 agents that we really haven't talked much about that remain on this list are Nivo and Pembro. And I know certainly that those agents have had their FDA approvals taken or rescinded, but there is maybe some utility in using these agents if patients have never been exposed to these in the first-line setting. So talking to our experts here, are there ever times that, how are you choosing your second-line agents when you're looking at this list that can often be confusing when there's just a laundry list?
Yeah, that's a great point. First of all, I just want to highlight our edgy, do they reflect the latest data and modern care principles? Are the NCCN guidelines relevant? No, I'm being dramatic. But I do think there's a lot to actually debate here. I mean, we still have bendamustine on here. The guidelines are often kind of an array of options too, and then narrowed down to specific recommendations. So let me start with your specific question before I dive into the other aspect I wanted to discuss of that, which maybe I'm starting to lean toward. So Pembro and Nivo, I should point out that where it says relapse greater than 6 months, preferred regimen, original regimen, that is without the checkpoint inhibitor if the progression happened on the checkpoint inhibitor. So in somebody who's on maintenance, atezo or durva, at the time of progression, it's going back to platinum etoposide, essentially, that is the preferred regimen. And then I'll come back to further comments on that in a moment. Nivo, Pembro are on there based upon the single-arm studies for each of those that did show responses and did show durability, but in a fraction of patients. Later studies that were randomized were essentially negative trials when compared to Topotecan in the second-line setting for nivolumab and first-line Pembro study that Tiziana previously mentioned were negative, and therefore the companies pulled their applications for approval. But just because the applications were pulled is not to say that these are not of benefit to patients. And so in someone who has not been treated with a checkpoint inhibitor, most commonly that really is limited stage small cell that's treated with chemo, radiation. Then at the time of progression, I definitely would consider Pembro or Nivo. These are home run drugs when effective. When these work, they can work for years and with limited toxicities. Now, of course, there are toxicities that can come up, and I don't mean to say that this is what happens for everybody, but the best case scenario setting is often on one of these drugs. And so if somebody has never gotten a checkpoint inhibitor, I actually feel strongly about making sure that they at least get the opportunity for that, because when it works, it can work so well. And I have patients with more than 2 years of disease control on Pembro alone as a next line treatment option. And unfortunately, the majority of patients have progression. It doesn't work for everybody, all of that. But in the patients where it works, it is really a total game changer. I really just focused on the immunotherapy. I am happy to dive into more, but Tiziana, is there any aspect of this that sticks out to you as far as the next line treatment options?
Right, I do. I agree. I mean, I think this table is got a lot of options, and we reviewed the data. You know, we certainly can see that some of those options are still there because there is a potential benefit for selected patients. Using your clinical judgment in clinic is kind of my best sort of rationale for why they're all on there. I will say that the relapse greater than 6 months, having the preferred regimen as the original regimen, you know, I think these are consensus-based guidelines, but when I look at the Lerbinectedin data that we currently have with everything that we have available, the data actually looks the best for the platinum-sensitive population. So I think if I have a patient in clinical practice who's had prior platinum etoposide, atezo, and this was a patient that really struggled with certain toxicities that I would really be worried that re-challenge with carboplatin etoposide could be detrimental to their quality of life, I would certainly favor using Lerbinectedin in that patient population in the relapse greater than 6 months. For patients with relapse 6 months or less, I tend to favor using Lerbinectedin or Irinoteken. I generally avoid Topotecan given the significant myelosuppression, especially if they're platinum resistant and they've had recent carboetoposide. Myelosuppression is a significant problem. For patients who have had prior brain radiation and who have now progression, and I'm worried about CNS progression, I have had success with temozolomide. We have limited data with CNS, with Lerbinectedin, given that patients were excluded in the Lerbinectedin trial if they had brain mets. So those are sort of my own interpretations of the data, and as I treat patients and talk to patients and see their follow-up, kind of how it's molded my practice patterns based on my interpretation of the data. You know, although I agree with you, this is like the hardest to see a patient who has platinum etoposide and they have progression and never had the chance to get an IO. Then I go back and read the Checkmate 331 data, which was Nivo versus Topotecan, and it was stone cold negative. So although I agree that there is this unknown small subset of patients who may have a really great benefit from IO, I don't think it's the majority of our patients, and I think they only have one next step in terms of a treatment that they could benefit on. That being said, in that sort of situation for a patient that has small cell and has never received IO, I really try hard to get them on an IO combination trial with a new combination strategy through our phase 1 group or through our lung group, and really try to push hard for an IO-based combination strategy but try to stay away from monotherapy because I feel like the data really does not support, Nivo versus something else. And in that sort of patient, I certainly would go to Lerbinectedin, go to Irinoteken, clinical trial with IO combinations, or a novel mechanism of action that we'll talk about some of the newer agents that are coming up.
That's an important nuance. So I absolutely agree with you. The likelihood of responding to one of the checkpoint inhibitors is quite low. And so if I have somebody who's very symptomatic, has bulky volume of disease, I'd be more inclined to go on to one of the other chemo agents. And in someone who has radiographic progression, not really symptomatic, where I feel like we have some time, then that's the setting where I'd be more inclined to consider checkpoint inhibitor. I also completely agree with you as far as platinum etoposide. I'll admit I'm actually not a big fan of platinum etoposide retreatment in general because there is toxicity with platinum etoposide, and the likelihood of response or the durability of the response is not going to be as good in the next line as it was in the prior, and so we get less benefit. Now, that being said, someone who has a year of control, that's compelling to you. So this is certainly a regimen to continue to consider. I'll admit that it's not my personal preferred regimen. It's something to discuss. And Lerbinectedin, you're right. There were 20 patients in the trial. This was published in Lung Cancer. 20 patients that had a chemotherapy-free interval of more than 6 months. So it's small numbers, but was even more compelling in that group as well. And then I'll just highlight for everybody, this list on NCCN guidelines is very long. We've narrowed it down to essentially about 5 drugs to discuss, and I think those are the most relevant ones that are on the list. So going back to the case now, this is a second-line maintained performance status, ECOG-1, 5-month chemotherapy-free interval after progression on maintenance atezolizumab, platinum etoposide, atezo. Nisha, I'll ask you because we talked about Pembro and Nivo, but where do you weigh in on that as far as a treatment option? Is this something to consider at all? Is this something that when would you use it if you use it?
So if it's similar to what you guys have said, if they've never had IO, if it was a limited stage and they progress, I might reserve it for third line, depending on how quickly their disease is changing. I will probably use, if possible, Lerbinectedin if there's a quicker progression. So I don't use single agent IO typically as my second line unless they've never had it before. And again, I would probably reserve it a little later.
Yeah. And just to stress, in someone who's had progression on a checkpoint inhibitor, these are not options if someone's had progression on atezo or durva. The question came up, does Lerbinectedin have activity in brain metastases? The trial did not allow for that. And it's not a drug where I would expect it to have good CNS penetration. That being said, I have one patient that actually had a radiographic intracranial response to therapy. So I did have one patient with a response. That's not something I would really rely on or consider likely. Okay. Maybe for the sake of time, let's go on to the other trials, and then we can have more discussion pending time. So first of all, we're just going to start out with small cell subtypes because I'm very hopeful that this is really going to offer a different framework for the field. Non-small cell lung cancer, we now have these various subtypes, and even beyond the subtypes now is further genomic subclassifications. Within small cell lung cancer, this is a fairly new idea. This is something that came out of both Charlie Rudin's lab at Memorial Sloan Kettering and Lauren Byer's lab at MD Anderson, both proposing pretty similar subtyping. And this is actually from the Charlie Rudin publication. Well, let's dive into some of what these subtypes mean. I guess before I turn it over to you, I'll just say that what you saw there are 4 IHC stains, which really correlate with RNA-seq expression as well as the way that Dr. Byers had separated those out. But 4 IHC stains which describe 4 subtypes of small cell lung cancer, which have different features. Now, these don't seem to be as solid as what we see in the non-small cell lung cancer type subtyping. that I described. So this is not entirely analogous, but may have real implications into defining which populations are more likely to respond to some of these investigational drugs we're discussing.
And if you could go back to that prior slide, I guess one point that I'd like to make in these 4 subtypes is, they're really based on the RNA-seq data that you mentioned, and there was a really interesting presentation at AACR 2022 where they actually did correlation between results from Gay's lab and from Rudin's lab and saw that their methods had very high agreement to differentiate between the subtypes that had neuroendocrine features, which is the ACL1 and the NeuroD1, versus the non-neuroendocrine, which was the YAP1 and the PAUTF3. But in the sort of the non-neuroendocrines, they had the highest concordance. And so there was differences in terms of the percentage of subtypes for each one with the ones that had neuroendocrine differentiation. For example, in the Rudin lab, 84% had the type A, and then in the Gay lab, lower in the type A. But similar results, for example, in the YAP1, which was about 8%. So it is something that I think is still evolving in terms of, concordance, and how do we roll this out as we try to investigate these subtypes in terms of, are these prognostic? Can we perhaps use these to really define who benefits from certain types of therapies? And so we've seen some exploratory data from both Empower and Caspian that we'll talk about. There is a result from the Empower 133 looking at gene expression analysis in the long-term survivors, really showing some trends observed with the small cell lung cancer subtype I, or the YAP1. That's the inflamed subtype, the one without the neuroendocrine markers. And what they saw was that in the atezolizumab arm, 55% of the inflamed subtype were long-term survivors, and in the placebo arm, 30% were long-term survivors. And there was a higher percentage of the inflamed subtype were in the long-term survivors than non-long-term survivors. So kind of suggesting that there's some enrichment of the YAP subtype in patients in the atezolizumab arm that were long-term survivors. But certainly this is sort of very descriptive, exploratory in nature, and the benefit really in the long-term survivors, they saw in the atezo arm benefit in all subtypes. But sort of that initial discussion of perhaps this inflamed subtype, which has the immune cell infiltrate, is this perhaps a subtype most likely to benefit from immunotherapy? And we've now seen this sort of similar theme in an exploratory analysis of the Caspian data as well. You see here both the Guy method and the Rudin method, where they saw, again, numerical improvements here in median OS in the Durva plus EP in the YAP1 subtype, which is the inflamed subtype. So certainly very interesting and exploratory in nature, but I think we really should start looking at this in trials in a prospective manner. And then again here, looking at this inflamed subtype, looking at inflamed signatures with high T cell, longer survival in the Durva plus EP arm. So more to come on that, but I think this is an exciting time to really explore predictive biomarkers, and perhaps, there might be something here, and we're really looking forward to seeing more of this in prospective trials.
Before we go on to that, there's a question here. Since RNA expression can change quickly, are these small cell lung cancer subtypes static or dynamic? And so, there's still a lot to learn about this. This is very much a proposal. This has really came from testing in labs. I think what we're seeing in practice, at least in early data, is that these are not static and that this is something that can change, as well as the fact that these maybe aren't as clearly distinguished in real-world cases as they are in these in the lab, in the lines. And so there's still a lot to learn from this. I think this idea is a framework that we're very hopeful will lead to what we're describing as far as better describing populations or using this as biomarkers for likelihood of response to therapies. But it does, at least in early data, is a bit messier than just static classification.
And I think certainly that there's a lot of interest in the use of radiation and what is the role and timing of radiation with some of these novel IO combinations. So there are a couple of trials that are evaluating that. The NRG LU007, otherwise known as the Raptor trial, is looking at the role of radiation in extensive stage disease. So patients will get platinum-based chemotherapy plus atezo, and then will be randomized to either atezo or atezo to radiation, and this can be up to 5 sites that can be radiated. Again, they're using kind of moderate doses of radiation, anywhere between 30 and 45 gray, but will help answer that question of does consolidative radiation or radiation after chemo IO add benefit. The trial is phase 2-3, so phase 2 is looking at PFS, phase 3 OS. And then certainly limited stage disease, a lot of interest in how to utilize immunotherapy, and there are a couple of trials going on. The NRG LU005 is looking at chemo RT with the addition of immunotherapy with the second cycle of chemotherapy during concurrent treatment. And then the Adriatic trial is looking after the completion of chemotherapy and radiation, either using Durva-Tremi, or compared to placebo, to answer some of these questions of radiation and IO timing and sequence.
Now, the Skyscraper 02 study, this was anti-TIGIT added to carbotopicide plus minus anti-TIGIT. This is going to be discussed, and actually the abstract is not yet available for review. But in a press release, this was a negative trial. I'm very interested to learn the details on this, and so this is, I believe, on Sunday we'll see this.
And this is an ongoing study actually exploring a new agent in combination with chemotherapy and nivolumab in extensive stage small cell lung cancer. This is BMS 986012, which is actually, it's a fucosyl monoclonal antibody, anti-fucosyl monoclonal antibody. You know, the fucosyl GM1 is a ganglioside that is highly expressed in small cell lung cancer. And what we think that it does preclinically is that it binds to tumor cells and activates antibody-dependent cell-mediated cytotoxicity, increases T-cell anti-tumor activity, and then hopefully will sort of synergize with nivolumab. In the phase 1-2 experience with BMS and nivolumab, they saw that this combination was well tolerated, with the main side effect being pruritus, which was mainly grade 1 and 2. And then they also saw really interesting response rates of this combination in patients with relapsed small cell lung cancer, with an overall response rate of 38% and a median duration of response of 26 months. So this has led to now this combination strategy in the front line, a randomized phase 2 study of BMS in combination with chemo plus Nivo versus chemo plus Nivo. This study is ongoing. They are trying to do pre-treatment biopsies, to really look at expression of, the marker, and really trying to see if they can really have a predictive biomarker there. But I do think that really hinders clinical trial accrual. And so, this trial has been going on for a while, and we really are looking forward to seeing some of these results.
Not just hinders, interestingly, I think it also shifts the population that you're enrolling. Within small cell lung cancer, you have many who are very rapidly progressing, and those patients are less likely to end up on the trial.
SWOG is doing a phase 2 trial looking at the addition of talazoparib in patients with SLFN11 positive disease. So again, this is in the maintenance setting after 4 cycles of chemo immunotherapy. And what preclinical data suggests is that when you have DNA damage response inhibited by PARP inhibitors, it can lead to PD-L1 expression and T-cell re-engagement, and typically SLFN11 seems to be a predictive biomarker of sensitivity to PARP inhibitors. So that's the rationale for kind of doing a biomarker-specific maintenance approach.
So just to briefly touch on others, there are some interesting questions here I want to get to. I know we're running out of time. So I'll just mention there's the Resilient trial. This is liposomal Irinoteken, and you see some data there with responses. Bispecific T-cell engagers, trispecific T-cell engagers. This is an exciting category of drugs to me where really the immunotherapy responses that we get, these are really the most durable. We're currently enrolling to a trispecific trial. We're opening the AMG 757 study, and we do have data from that last year. And you see the waterfall plot there at the top with responses to therapy. Most of the toxicity is really cytokine release syndrome, and so these studies do require admission to the hospital, at least in the beginning. But for patients that do well, then that can then be done as an outpatient. Aside from cytokine release syndrome, generally very well tolerated. And then Lerbinectedin, there are ongoing studies. This is the Lagoon trial. It's a combination Lerbinectedin plus Irinoteken versus Topotecan or Irinoteken, so another ongoing trial. But I want to get to some of these questions before time runs out. So here's an interesting, well, first of all, actually, just because this was brought up about subtypes, again, is it standard to search among small cell lung cancer groups and adjust the therapy accordingly? I'd say this is not a standard of care. There are centers that are now, as a standard, doing these IHC stains and subtyping and categorization, but that's not really part of what I'd consider current standard practice. But this one I want to get to. So the terms chemo-resistant and chemo-sensitive, does that still hold in the IO era? Of course, those come from when platinum etoposide was the only treatment. So now a patient who has maybe some control with checkpoint inhibitor, how does that impact how you categorize? Do you shift your categorization? What time frame do you use to define your platinum sensitive?
So I think the term platinum sensitive, platinum refractory, as you can tell by different definitions in different studies, is not well established. So I think from a clinical practice standpoint, we've just decided to come to consensus that we're going to call platinum refractory, 6 months or greater, platinum sensitive, less than 6 months, platinum refractory. But I think, that is in itself a definition that is really not well established. Now, we're opening another sort of a door there about how do you define IO resistance. We're still kind of struggling with how to define that in non-small cell. And, certainly I don't think we have it well established what is IO resistant in small cell. The issue with small cell is because we're using it in the maintenance setting, you're seeing patients having progression at the 6-month mark. So if you think about that, that's the median PFS of these regimens, Atezo and Durva. You see that the, majority of the patients are unfortunately going to have median PFS of about 6 months. So they're actively progressing on IO maintenance therapy. So in that situation, they're essentially IO refractory in my mind clinically, and then it's time to move on to another combination or another strategy or a novel clinical trial.
The question came up, is there rationale for combining Lerbinectedin with trilaciclib? Now, we didn't really talk about trilaciclib because we're more talking about cancer therapeutics, and but this is a supportive therapy. We didn't really go into GCSF either, I suppose. But either of you, any comments on trilaciclib in the last bit here? Not big ears. So I'll
tell you what we've seen the pooled analysis data, and it's included combination strategies in the front line. So carbotope, immunotherapy with the CDK4/6 inhibitor, which is trilaciclib. It has approval in the front line as a myeloprotective agent. We've seen the results of the pooled analysis that included, phase 2 studies of carbotope, Atezo, plus trilaciclib, carbotope plus trilaciclib, and then topotecan plus trilaciclib. So it has a myeloprotective effect. It doesn't interact with the other agents in the sense that it doesn't seem to add or cause detriment in terms of PFS and OS when you combine it. So I would think that, if you combine Lerbinectedin with trilaciclib, certainly the rationale would be similar, that it would have a myeloprotective effect. That study has not yet been done, but I've heard of investigators that are interested in doing that study, so perhaps it's coming.
Yeah, so trilaciclib is approved for platinum etoposide, also approved for Topotecan. This has been a lot of fun. Thank you. Thank you to my colleagues for joining. Thank you all for attending.
This activity is certified by PVI, Peer Review Institute for Medical Education. Remember to download the slides and practice aids.